Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. NIK NIKAM. I have been a cardiologist for more than 30 years at the Texas Medical Center in Houston, Texas. Today we are going to look at hypertension management and also look into JNC 8 recommendations. So let us begin. The objectives of this presentation include definition of hypertension in the adult population, epidemiology, types of hypertension, namely primary and secondary. Then we are going to look at the clinical presentations and complications of untreated hypertension. Next, we are going to look at the 9 recommendations that came from the JNC 8 Working Committee in 2013, medical management of hypertension based on the guidelines, special clinical presentations such as heart failure, renal failure, stroke, myocardial infarction. Next, we're going to look at hypertensive urgencies and emergencies, and finally conclude with the benefits of treating hypertension in the adult population. Hypertension is one of the most frequently encountered diseases in the adult population for the family doctors, primary care internists, and also cardiologists. There are approximately 70 to 80 million people in this country who have hypertension, and the numbers are just going to continue to increase as the baby boomers reach the 6th, 7th, and 8th decades. As you can see, the incidence of hypertension goes out proportionately with the increase in the age of a given person or a patient. Between ages 18 to 34, the incidence of hypertension is only 6%, whereas that goes up by almost tenfold by a person reaches the age 65 to 74. And it is interesting to see above age 75, almost 8 out of 10 people have some manifestations of arterial hypertension. The cost of treating diabetes was approximately $198 billion in the year 2010, and it is likely to go up to $264 billion in 2030. Similarly, the cost of hypertension was $131 billion in 2010, which is going to surpass the cost of treating diabetes, and it may reach $289 billion by 2030. So hypertension is one of the most important problems we are going to encounter in the adult population. There are 2 types of hypertension, namely primary hypertension and secondary hypertension. Primary hypertension accounts for 95% of the hypertension we encounter in clinical practice. It is also called as the essential hypertension, and it has no universally established cause. Whereas the secondary hypertension accounts for less than 5% of the hypertension that we encounter in clinical practice. Generally, the secondary hypertension is secondary to an underlying cause which may be treatable in most cases. Why do we need to treat hypertension? Uncontrolled hypertension can lead to myocardial infarction, stroke, renal failure, aortic aneurysm, aortic dissection, retinal bleeding, and even death. Let's look at some of the end organ effects of uncontrolled hypertension or poorly controlled hypertension. Cardiovascular system. Uncontrolled or poorly controlled hypertension over a period of decades can cause left ventricular hypertrophy, dysfunction, and eventually left ventricular failure. Hypertension can also lead to arrhythmias, increased incidence of coronary artery disease, and acute myocardial infarction. It also can cause arterial aneurysm, dissection, and rupture. Hypertension has a significant effect on the kidneys. It can cause glomerular sclerosis, leading to impaired kidney function, and finally end-stage kidney disease. Hypertension is one of the main causes for chronic kidney disease. Hypertension can also cause ischemic kidney disease, especially when renal artery stenosis is the cause of hypertension. On the nervous system, hypertension can lead to stroke, intracerebral or subarachnoid hemorrhage, and cerebral atrophy and dementia. Hypertension also has significant effects on the eyes. It can cause retinopathy, can also lead to retinal hemorrhages and impaired vision. It can cause vitreous hemorrhage, retinal detachment, and also neuropathy of the nerves, leading to extraocular muscle paralysis and dysfunction. Now let's move on to how we diagnose hypertension or how we evaluate a patient with suspected hypertension. When a patient comes to the office or you see the patient in the emergency room for the first time, it is appropriate to measure their blood pressure in both arms. Look in the optic fundi for vascular changes in the retina. We also need to calculate the BMI because weight also has a direct effect on hypertension. Auscultation for carotid, abdominal or femoral bruise. We should make it a routine to palpate the thyroid gland for any evidence of enlargement. Here are the routine labs that we should be performing in order to evaluate a patient with hypertension, which should include electrocardiogram, urinalysis, blood glucose level, and lipid panel, along with the thyroid studies, any evidence of urine protein, and also calculate glomerular filtration rate. The four main classes of drugs recommended by the JNC 8 committee include ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, and calcium channel blockers. You may be surprised what happened to the beta blockers. What about all the other antihypertensive medications that are available today to treat patients with hypertension? We are going to look into each one of those categories and see where they stand in the management of hypertension and how they influence the outcomes of hypertension complications. Before we go any further, we are going to look into JNC 8 committee recommendations. I said these are committee recommendations because the National Heart, Lung and Blood Institute was in charge of JNC recommendations for management of hypertension patients. However, the recommendations from the committee on JNC 8 were never endorsed by the National Heart, Lung and Blood Institute, and neither was it approved by any other medical society, including the American College of Cardiology and the American Heart Association. So in fact, JNC 8 is not a National Institute of Health recommendation. It is just a consensus opinion of the JNC 8 committee. But nonetheless, these recommendations have been used for guiding therapy for patients with hypertension in the adult population. The recommendation 1 included in the general population age 60 and over, initial pharmacological treatment to lower the blood pressure at a systolic blood pressure of greater than 150 millimeters of mercury and a diastolic blood pressure of greater than 90 millimeters of mercury. In other words, the target for treating an adult patient greater than 60 years is blood pressure greater than 150 over 90. And the goal of treatment is to achieve a blood pressure less than 150 over 90 millimeters of mercury. However, the committee did not say how much lower we need to bring down the blood pressure with antihypertensive medications. They also added a footnote here that if the blood pressure comes down below 150 over 90, they did not recommend reducing the dosage or adjusting the medications. So this was the only grade A recommendation based on randomized control trials. whereas most of the other recommendations don't even reach the threshold of grade A recommendation. And we're going to look at the remaining 8 recommendations by the JNC committee. The second recommendation said that in the general population less than 60 years, initial pharmacological treatment goal is to keep the diastolic blood pressure less than 90 millimeters of mercury. This again has a split grading. Only for ages 30 to 59 did they find a strong evidence, and it was given grade A based on the randomized controlled trials, whereas for ages between 18 and 29, the expert opinion was much weaker compared to the population between 30 and 59. Recommendation 3 said that in the general population less than 60 years, initial pharmacological treatment to lower the blood pressure at a systolic blood pressure greater than 140 millimeters of mercury, and the goal is to bring the blood pressure below 140 millimeters of mercury. In other words, patients who are less than 60 years of age, the threshold for treating hypertension should include a blood pressure greater than 140 millimeters systolic. Again, this had a grade E recommendation. Recommendation 4 said in population age greater than 18 years, that is adult population with chronic kidney disease, the initial pharmacological treatment is to lower the blood pressure below 140 systolic and below 90 diastolic. Again, this had a grade E recommendation, most of which was based on expert opinion because the randomized controlled trials did not have strong evidence to suggest these recommendations. Recommendation 5 looked at population age greater than 18 years with diabetes. The threshold here is to treat anybody who has a blood pressure greater than 140 over 90 millimeters of mercury, and the goal is to bring the blood pressure below 140 over 90 millimeters of mercury. Again, the recommendations are based on expert opinion because there was not a strong evidence to suggest grade A recommendation. Recommendation 6, in the general non-black population, including those with diabetes, initial antihypertensive treatment should include a thiazide type diuretic or a calcium channel blocker or an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. Here the evidence was grade B. Recommendation 7, in the general black population, including those with diabetes, initial antihypertensive treatment should include a thiazide type diuretic or a calcium channel blocker. In the general black population, the recommendation was grade B, whereas in the black population with diabetes, the recommendation was even weaker. It was grade C. Recommendation 8, in the general population age greater than 18 years with chronic kidney disease, initial antihypertensive treatment should include an angiotensin converting enzyme inhibitor or an A or B to improve kidney outcomes. Again, I want to underscore the word kidney outcome. They did not talk about reducing cardiovascular events, which is most often used for looking at the benefits of antihypertensive medications. However, in patients with chronic kidney disease, the main focus was on improving renal outcomes. This applied to all chronic kidney disease patients with hypertension regardless of race or diabetes status. Again, this was a grade B recommendation. And finally, we have recommendation 9. The main objective is to obtain a target directed blood pressure control. If the blood pressure is not controlled within a month, it is reasonable to increase the dose of the first medication or add a new drug and continue observation for a 1 month period. If the blood pressure is still not controlled, then add a third drug or titrate the dose of the second drug. Again, this was just an expert opinion and it was given grade E. The JNC 8 working committee also said there were no good randomized trials comparing the following drugs to the 4 recommended class of drugs which we already talked about. So they didn't find any strong randomized control trials suggesting these agents made a profound difference in the cardiovascular or renal outcomes. So these drugs include dual alpha and beta blocking agents such as carvedilol, vasodilating beta blockers such as nebivolol, central alpha-2 adrenergic agonists such as clonidine, direct vasodilators hydralazine, aldosterone receptor antagonists such as spironolactone, adrenergic neuronal depleting agents such as reserpine, or loop diuretics such as furosemide. It is interesting, we do use these drugs in combination with the 4 main classes of antihypertensive drugs on a routine basis. However, these drugs did not show significant improvement in cardiovascular outcomes when they were used as sole antihypertensive agents. That brings us to what's the controversy. There are several controversies regarding this JNC 8 recommendations. The American College of Cardiology and American Heart Association has not endorsed these recommendations, and also they have not come up with their own guidelines for management of hypertensive patients. In addition, they also question about the target for treating adult population beyond the age 60, which is 150 over 90 millimeters of mercury. The ACC and the AHA feel that there is continued benefit by keeping the blood pressure target at 140 over 90 millimeters of mercury, and with continued decrease in blood pressure, they feel there is decrease in cardiovascular morbidity without citing any definite references. But nonetheless, that's the standing by the American College of Cardiology and the American Heart Association. But what is interesting is that beta blockers are no longer considered the first line of drugs in the treatment of adult population with hypertension. Of course, we're going to look at conditions where beta blockers do play a role in reducing cardiovascular endpoints. Similarly, ACE and ARBs were not the first line of drugs in African American patients unless they had evidence of chronic kidney disease. Again, there is absence of specific recommendations for ACE inhibitors or ARBs in diabetics in the absence of proteinuria. So these are some of the gray areas which were not clearly addressed by the JNC 8 committee. How do we approach a patient in an office or in a hospital when they present with hypertension for the first time? If we are dealing with an adult population with hypertension, first we need to recommend lifestyle modification, set the blood pressure goal, initiate blood pressure lowering medications based on the algorithm. Again, this is the algorithm based on JNC 8 hypertension guidelines. Older than 60 years, the goal is to bring the blood pressure below 150 over 90 millimeters of mercury. And this can be accomplished by starting with either a thiazide, ACE, ARB, or calcium channel blocker alone or in combination. If we are dealing with a person who is 60 years or younger, the aim is to keep the blood pressure below 140 over 90 millimeters of mercury. Again, we use these combinations for non-blacks, and if we are dealing with black population, we start them with a thiazide diuretic or a calcium channel blocker, and then add more drugs as needed. In patients with history of diabetes or kidney disease, for all age groups with diabetes, the treatment goal is 140 over 90 millimeters of mercury, and again the bifurcation comes down to non-blacks and blacks. If we are dealing with patients of all ages and races with chronic kidney disease, with or without diabetes, again the goal is to keep the blood pressure below 140 over 90 millimeters of mercury, and these patients can be started on ACE inhibitors and ARBs alone or in combination with other classes of drugs depending on the response to the initial treatment. If we are not able to reach the blood pressure goal, then we need to reinforce lifestyle changes and titration of the first medication to its maximum dose, or consider adding a second drug which can include an ACE inhibitor, ARB, calcium channel blocker, or a thiazide diuretic. After 2 drugs and lifestyle modifications, if the blood pressure goal is not reached, we can add a third drug or drugs which are not mentioned in the JNC 8 guidelines, and then continue the treatment to achieve the goal. So, to sort of recap what we said, if we are dealing with non-black population, the initial treatment can include an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker or a calcium channel blocker or a thiazide type diuretic. However, if we are dealing with a black population, including those with diabetes, they can be started on a calcium channel blocker or a thiazide type diuretic. If we are dealing with a chronic kidney disease population, regardless of whether they have diabetes or not, we should consider ACE inhibitors and ARBs as initial or add on antihypertensive treatment to preserve renal function. Before I go any further and explore these various antihypertensive medications, let us look at some of the major contraindications for using various antihypertensive medications. As a cardiologist, I always look first for what is a contraindication for using a drug. It is so easy to pick a drug, but it is quite challenging to see why we should not use a given particular drug. For example, ACE inhibitors should be avoided in patients with pregnancy, or patients who have a history of angioedema, or patients who have hyperkalemia, or patients who have bilateral renal artery stenosis. There you go. We should avoid ACE inhibitors or ARBs in these types of patients. Once we have established the pre-existing conditions, then it will help us to choose the most appropriate drug for that particular patient. Similarly, calcium channel blockers should be avoided in patients with heart failure with a left ventricular ejection fraction of less than 40%. This becomes an important factor in cardiology when we are dealing with patients with hypertension, heart failure, and low ejection fraction. Diuretics should be avoided in patients with gout. Diuretics can lead to glucose intolerance, metabolic syndrome, hypercalcemia, and hypokalemia. Beta blockers should be used in caution in patients with asthma and also in patients with diabetes, as beta blockers can mask the symptoms of hypoglycemia. Again, beta blockers are not one of the groups of drugs recommended as the first line of treatment, contrary to JNC 7 guidelines. We should also be cautious in using beta blockers in patients with significant bradycardia or second degree or higher AV block. Beta blockers can also induce metabolic syndrome, glucose intolerance, and interfere with athletes and active patients. Beta blockers may also be a major cause for sexual impotence. Beta blockers may also exacerbate symptoms of chronic obstructive pulmonary disease. Now, let's say we have started the patient on the first drug of choice, and if that drug is not able to bring down the blood pressure, which drug do we choose next? This chart kind of helps us to decide on what is the second drug we would like to use in these patients based on some pre-existing conditions. If the patient is receiving an ACE inhibitor or an A or B, and we want to add a second drug, particularly in the presence of diabetes or lipid abnormalities, then we should consider a calcium channel blocker. Whereas if we are dealing with a patient with heart failure or a stroke, then adding a thiazide diuretic may be much more appropriate. If we are dealing with a patient with a post-myocardial infarction or a patient with heart failure, then we should consider adding beta blockers, even though they are not the main drugs recommended for treating patients with hypertension based on the JNC 8 recommendations. If the patients are on beta blockers to start with, which is not the main recommendation by the JNC 8 committee, we can add calcium channel blockers in the presence of a coronary artery disease, but we should also be cautious of using calcium channel blockers along with beta blockers in patients with heart failure. So it becomes important to see what are the underlying problems we are dealing besides just hypertension in deciding the most appropriate combination of drugs in treating patients with hypertension. If we start off with a thiazide diuretic, it's reasonable to add a calcium channel blocker, and this would work good in both non-black and black patients. If we start off with a thiazide diuretic, we could add a beta blocker, but we should be considering glucose intolerance and metabolic syndrome, etc. If the patient is started on a calcium channel blocker, a beta blocker may be added, but we should be cognizant of the fact that they can make the heart blocks and heart failure worse. If the patient is receiving an ACE inhibitor or an A or B, a potassium sparing diuretic can lead to hyperkalemia. So now we are sort of trying to streamline the second drug option based on pre-existing conditions such as diabetes, renal failure, heart failure, hyperkalemia, and metabolic syndrome. If the patient is receiving an ACE inhibitor, we should avoid adding an A or B because of increased risk of renal dysfunction. But nonetheless, there are a number of patients who do receive benefit from a combination of ACE inhibitors and ARBs, and they should be appropriately chosen by specialists who are experts in managing malignant hypertension. If we use verapamil, we should avoid using beta blockers because of increased risk of higher grades of AV block or even complete heart block. Now let's look at some disease-specific treatment options. If we have a hypertensive patient with heart failure, it is reasonable to start them on ACE inhibitors or ARBs, as they are very helpful in improving the morbidity and mortality in patients with hypertension. We can also add a beta blocker, which has been shown to be beneficial in heart failure patients. Of course, they all benefit with diuretics by reducing the preload. And in advanced heart failures, we can add spironolactone, which has been shown to improve morbidity and mortality. Whereas if we are dealing with a patient with post-myocardial infarction or clinical coronary artery disease, ACE inhibitors, ARBs can be combined with beta blockers. If we are dealing primarily with patients with a coronary artery disease, we can use ACE inhibitors, beta blockers, diuretics, and calcium channel blockers. If we are dealing with patients with diabetes and hypertension, ACE inhibitors, ARBs, calcium channel blockers, and diuretics work well. If you are dealing with a patient with a chronic kidney disease, we should be considering ACE inhibitors or ARBs. Patients with recurrent stroke should be treated with ACE inhibitors and diuretics, and patients who have pregnancy, the first line of drug should be labetalol, followed by nifedipine and methyl dopa. You may be wondering, what is methyl dopa? That's the ultimate, which is the good old drug that has been used for decades for treating patients with hypertension during pregnancy. Now, we're going to look at individual classes of drugs, the starting doses and the maximum doses. And I'm not going to go through each one of these drugs. You can pause the video and look at these dosages so you memorize what you start with and what is the maximum dose for a given class of drugs. But it is important to understand that you cannot master all the antihypertensive medications. There must be approximately 30 to 40 different medications available in various classes. The best approach which I do and which I recommend is to learn one drug in each class thoroughly well, so that you know what dosage to start these patients on, how much you can use, what's the maximum dose you can use, and what other drugs combinations it can be used along with. So if you are talking about the diuretics, I generally stick to hydrochlorothiazide. In that way, I know exactly what is the starting dose, what is the maximum dose, and how it interacts with other antihypertensive medications. So starting dose is 25 milligrams daily. When we are using diuretics, again, we should look at the adverse effects such as hypokalemia, volume depletion, hypotension, hyperuricemia, and hyperglycemia or glucose intolerance. Let's move on to the next group. Here we have a long list of ACE inhibitors. I generally choose enalapril because most other drug efficacies were compared to enalapril. So you learn one drug from each class thoroughly well and see how it fits with other classes of antihypertensive medications, so that you can be confident when you use these drugs that you know what to expect and how the patients should respond. The dosage for enalapril is 5 to 40 milligrams daily or in divided doses. I usually give them in divided doses so that we reach a steady serum level throughout the 24-hour period, and it is especially true in patients with patients with heart failure, where 2 doses work much better than a single dose. And if you are fond of a different drug in this category, I would say you learn everything about that drug and stick to it. Then we need to be aware of adverse effects related to ACE inhibitors in general, which involves cough due to increased bradykinin release in the lung tissue, and these patients who have significant cough can be treated with ARBs, which does not cause cough or release of bradykinin in the pulmonary tissue. We should be aware of risk of hyperkalemia, renal impairment, and rare cases of angioedema. Patients who have angioedema, we should be careful in patients with angioedema related to ACE inhibitors when we consider an ARB. Now that brings us to ARBs or sardin, such as irbesartan, losartan, valsartan. Again, I would say you stick to one drug in each class. My favorite is losartan. I know the dose, 50 to 100 milligrams once daily, and it can also work better if you use them twice daily, so you get a steady serum level throughout the 24-hour period. And when it comes to ARBs, we should be aware of the adverse effects, namely hyperkalemia, renal impairment, and angioedema, which are similar to ACE inhibitors. Calcium channel blockers, I would stick to one of the newer drugs in this class, namely amlodipine. The dose range is 2.5 to 10 milligrams per day, and we should be aware of some of the adverse effects, which can be peripheral edema, flushing, headache, dizziness, hypotension, tachycardia, palpitations, or chest pain. Diltiazem has been around for a long time. You can use the long-acting diltiazem ranging from 180 to 360 milligrams per day, and verapamil may be useful in patients with significant chronic obstructive lung disease, where we may be hesitant to use beta blockers. That brings us to beta blockers. Even though the beta blockers have dropped off the radar of JNC 8 recommendations, beta blockers do play a significant role in patients with the cardiovascular problems to begin with, in terms of reducing cardiovascular morbidity and cardiovascular mortality. Among the beta blockers, for the last 2 to 3 decades, I used atenolol with great success. The dose ranges from 25 to 100 milligrams. It can be given once a day. But in patients with heart failure, the most widely used drugs include metoprolol and carvedilol. The dose of carvedilol is 12.5 to 50 milligrams daily in 2 divided doses. Similarly, long-acting metoprolol can be used in dosages ranging from 50 to 200 milligrams twice daily for control of hypertension. They are also useful in patients with heart failure, and some of the side effects which we need to be concerned about with beta blockers include bradycardia, hypotension, worsening of heart failure, bronchospasm, and worsening of conduction disturbances. There are other drugs which are sometimes useful when the standard recommendation drugs fail to achieve adequate blood pressure control in malignant hypertensive patients. Prazosin or Cordura or doxycycline are selective alpha blockers, and they work well in systolic hypertension patients. Similarly, spironolactone is also useful in patients with class 3 or class 4 heart failure in terms of improving overall morbidity and mortality. Here we have other drugs. For example, clonidine is very useful in bringing down the blood pressure on an acute basis. However, clonidine does carry significant side effects such as postural hypotension, constipation, bradycardia, and some sedation and dizziness. Hydralazine is another drug which is useful in patients with heart failure, especially class 3 and 4. Hydralazine should not be used in patients with acute coronary syndrome or active myocardial ischemia. Hydralazine can cause tachycardia and also lead to myocardial infarction. Methyl dopa has been used for decades for treating hypertension, especially in pregnant women. The side effects include sedation, dizziness, and hepatic necrosis. Hypertension treatment should begin with lifestyle modifications. Salt restriction should be on the top of the priority of hypertensive patients. The salt restriction should be to less than 5 to 6 grams per day. Alcohol should also be restricted to no more than 1 ounce per day. The BMI is another important factor. The goal is to have a BMI of 25 kg per meter square, which may be impossible in obese and morbidly obese patients, but nonetheless Weight reduction can dramatically bring down the blood pressure and also reduce the number of medications needed to control the blood pressure. Exercise also helps to reduce the blood pressure and reduce the number of medications we need to treat a hypertensive patient, because exercise combined with all other modalities of lifestyle changes leads to weight reduction, which also helps to bring down the blood pressure. Now let's look at antihypertensive crisis. There are two main categories, namely hypertensive urgencies, where there is no progressive target organ dysfunction. Basically, we have an accelerated or uncontrolled hypertension without major symptoms. Then we have hypertensive emergencies, which present with progressive end organ dysfunction, the target organs which we talked about, along with extremely high blood pressures. Let us see how we manage these patients. If we have a patient with hypertensive urgency who has a blood pressure of greater than 180 over 120 millimeters of mercury without progressive end organ dysfunction, they can be treated on an outpatient basis. They can be treated generally by using oral medications, and there is no need to use intravenous medications in these patients. If patients with hypertensive urgencies are admitted to the hospital for other reasons, then these patients can be treated with antihypertensive medications with the main aim to bring down the mean arterial pressure by 25% in the first 24 hours, or a target of blood pressure less than 160 over 100 millimeters of mercury. Rapid correction of blood pressure below autoregulatory range can cause ischemia, which can lead to cerebral stroke, myocardial infarction, or acute kidney injury. Please keep these in mind. A rapid reduction in blood pressure can be more harmful than beneficial. The only circumstances in which you would want to bring down the blood pressure rapidly would include aortic dissection or cerebral aneurysm, or patients with high risk of myocardial infarction. Hypertensive emergencies. This is a different category. This is a situation where we have blood pressure greater than 180 over 120 millimeters of mercury in association with the target organ dysfunction, requires emergent lowering of blood pressure, and in most cases we may have to use an intravenous drug in the form of infusion to bring down the blood pressure steadily but promptly. Examples of severely elevated blood pressure include hypertensive encephalopathy, acute left ventricular failure with pulmonary edema, or a patient with acute coronary syndrome, or a patient with a dissecting aortic aneurysm. Here are some of the intravenous drugs that are available, and when we use these drugs, again we need to understand the underlying condition, that is the target organ damage that we are dealing with, because some drugs work better for certain situations. For example, a nitroglycerin infusion may work better in patients with myocardial ischemia or myocardial infarction or acute coronary syndrome. The drugs available include sodium nitroprusside, nicardipine, clevidipine, phenoldipam, nitroglycerin, IV enalapril. IV enalapril is just given every 6 hours, or hydralazine. And here are the dosages given, which I'm not going to go into each one of them individually, but it also tells us how quickly these drugs work, what is the duration of action, what are the adverse effects, and what are the special indications for which they are used. As I mentioned before, if we are dealing with the coronary ischemia, I would choose nitroglycerin. If we are dealing with a patient with glaucoma, then you could use phenoldipam. Enalapril is useful if we are dealing with an acute left ventricular failure or chronic heart failure. And if you're dealing with eclampsia, then using hydralazine may be a better choice. So please review these charts and choose the drugs appropriately based on the target organ dysfunction that we are dealing with. We also have beta blockers such as labetalol or esmolol, which are useful in patients with aortic dissection or heart failure, and phentolamine, which may be useful in patients with catecholamine excess. Now let's talk about specific conditions associated with malignant hypertension or accelerated hypertension. If we have a patient with pulmonary edema who has hypertension, the goal is to reduce the preload and afterload. The goal is to improve and maintain contractility, and the goal is to maintain stroke volume. So we can use nitroglycerin to reduce the preload. We can use diuretics to reduce the preload. We can also add beta blockers to improve the overall function in patients with heart failure. If we are dealing with aortic dissection, the goal is to reduce shear stress. The goal is to reduce shear stress, heart rate, and velocity of blood flow. And this can be accomplished by using beta blockers such as labetalol or a combination of esmolol and nicardipine. And here we need to bring down the blood pressure as quickly as possible, and the target is to bring the blood pressure below 120 over 80 millimeters of mercury. If we are dealing with a patient with a stroke, the aim is to reduce the blood pressure as quickly as possible. For thrombolytic therapy, we need to make sure the blood pressure is below 180 over 105 millimeters of mercury. We can use labetalol or nitroprusside if the blood pressure is greater than 120 over 120 millimeters of mercury. If we are dealing with an hemorrhagic stroke, then it is a good advice to consult a neurologist. So we work as a team in managing these patients. Patients with encephalopathy, reducing intracranial pressure may be the main goal, and we can use labetalol or nicardipine. If we are dealing with sympathetic crisis, such as one we see in patients with cocaine or methamphetamines, we should theoretically avoid beta blockers, which can increase the alpha stimulation. The best drugs to use in these circumstances would be nicardipine or verapamil, and a beta blocker can be added if necessary. Now let's shift our focus to secondary hypertension. Secondary hypertension accounts for less than 5% of the hypertensive patients we encounter in clinical practice. The most common causes of secondary hypertension include intrinsic renal disease, which leads to hypertension, and accelerated hypertension leads to worsening of renal function and eventual chronic kidney disease. Renovascular hypertension is also uncommon. Then we may have mineralocorticoid excess, and of course hypertension can also be a feature of obese patients with sleep disorders. Uncommon causes include pheochromocytoma, glucocorticoid excess, coarctation of aorta, and either hyper or hypothyroidism. That's why when we do the initial workup, we should look for evidences of some of these conditions with routine lab tests, looking at TSH, looking at urine examination for proteinuria, or looking for any evidence of sleep disorders. If we are dealing with a hypertensive patient who is less than 30 years of age, we should always think about renal artery stenosis from fibromuscular dysplasia, or there's a typo here, or if you're dealing with a person who is greater than 55 years, we should think about atherosclerotic renal artery stenosis. Sudden in onset, we should always think about thrombus or cholesterol embolism. If the patient presents with episodic headache, chest pain, palpitations, and accelerated hypertension, we should always consider the possibility of a pheochromocytoma or thyroid dysfunction. If the patient is morbidly obese, snoring, we should look at sleep disorders as a cause of hypertension. If the patient manifests with a pallor, edema, or other signs of renal disease, or if there is evidence of abdominal bruit, especially in the diastolic component, we should consider renovascular hypertension. Truncal obesity, purple striae, buffalo hump may indicate hypercortisolism. If there is increased creatinine, abnormal urinalysis, we should look at renovascular or renal parenchymal disease. If there is unexplained hypokalemia, we should consider hyperaldosteronism. If there is impaired glucose tolerance, we should look at evidence for hypercortisolism, and impaired thyroid function tests should indicate either hypo or hyperthyroidism. Of course, renal parenchymal disease accounts for 2 to 5% of the hypertension population. Hypertension can also be a cause and consequence of chronic kidney disease. Multifactorial cause for hypertension include disturbances in sodium and water balance, vasopressors, and prostaglandin imbalance. Renal disease can result from multiple etiologies, and most of them do manifest with hypertension. So that brings us to the final slide as what are the benefits we can expect when we treat patients on a long-term basis for 4, 5, or 6 decades. What can we expect in terms of benefit? Treating hypertensive patients and controlling their blood pressure to the target limits can dramatically reduce the incidence of a stroke, averaging 35 to 40%, as much as 60% in the older population. Treatment of hypertension can reduce cardiovascular mortality and morbidity. It can reduce the incidence of myocardial infarction by an average of 20 to 25%. And heart failure, no question, hypertension is one of the major causes of advanced heart failure in the aging population. Controlling hypertension can dramatically reduce the onset of heart failure by an average of 50%, and there are plenty of reasons to control the blood pressure to the recommended target blood pressure levels. Ladies and gentlemen, thank you very much for your attention. I am Dr. NIK NIKAM, and please do subscribe to our YouTube channel. And on our YouTube channel NIK NIKAM, we have more than 130 lectures on cardiology, which can help physicians, medical students, primary care doctors, internal medicine physicians, and also cardiology fellows. Thank you very much for your attention, and we will see you next time.